I will be starting soon, yeah? Good afternoon, ladies and gentlemen. Thank you for joining us to commemorate the World AIDS Day 2021, which was on the 1st of December. The School of Medicine has lined up a series of webinars on health-related topics since the COVID pandemic. And today's theme of the public talk is Malaysia Today. Are we moving forward to end AIDS? My name is Kirti, a Year 3 medical student, and on behalf of Taylor's University, I would like to extend a very warm welcome to all of you. We appreciate you taking time off your busy schedule to join us today. We hope that you will find this program to be fruitful and engaging. First of all, let me introduce you to the agenda. We have 5 great speakers lined up for you, so don't forget to stay till the end for our group photo session. Before we start, I would like to remind everyone to mute your microphones. Next, please. Thank you. Okay, a reminder before we move on, if you have any questions during the presentation, you can scan the code of the Slido and type in your question later. We will bring them up at the end of each session. The link is also shared in the Zoom chat box. Please use the Slido link to send all questions and not send in the Zoom chat, as we would like to maintain the privacy of the participants. The QR code for the CPD points will also be shared at the end of the forum. Thank you. Without further ado, I would like to welcome Dr. Narendran Krishnasamy, a senior lecturer at Taylor's University School of Medicine, to introduce our first distinguished speaker.
Thank you very much. Good morning, ladies and gentlemen. This will be Dr. Dinesh Mahalingam, commonly known as, he prefers to be called as Javier. So we'll be talking on HIV care in Malaysia. He's basically a public health and occupational health specialist. After graduation, he started practicing as a doctor, and he has a work experience of 13 years. He has worked both in government and the private sectors, and currently he is the CEO of SP Care Group, running 13 medical clinics and extended primary care support facilities. He also has an enormous amount of NGO experience as well. One of it is he has started as a youth member, and then he progressed to a volunteer with Penang Family Health Care Department Association 1998. Later he became an EXCO member in 2009, and till date he holds a post of vice chairman in the state. He has been elected as an EXCO member of Malaysian AIDS Council in 2020, and currently serving as an interim vice president till date again. And he has been appointed as a medical chairman of Federation of Reproductive Health Associations Malaysia, and he holds the post till date. His main interests are sexual reproductive health and education, gender equality, and human rights, and his interest and expertise in the field of medicine, of dermatology, and occupational health. Ladies and gentlemen, let's welcome Dr.
Good morning, ladies and gentlemen, distinguished guests. Thank you, Dr. Nareen, for the introduction. I'd like to thank everyone for inviting Malaysian AIDS Council to be part of this program in conjunction of World AIDS Day 2021, which is organized by FRHAM, School of Medicine, Taylor's University, and other partners. Every year on the first day of December, the world comes together to remember lives lost to the AIDS virus since the start of the epidemic, and to show support for the estimated 37.7 million people living with HIV today. As you know, inequalities and AIDS and pandemics, the universal theme for this year's World AIDS Day is a rallying call for many nations to amplify their efforts to achieve the UN AIDS goal of ending AIDS 2030. This campaign is being vigorously implemented in all the affected countries in the efforts to battle the pandemic. Malaysian AIDS Council has always adhered to the principle of equality and humanitarian values that every individual, regardless of race, gender, sexuality, and socioeconomic status, has the right to live a healthy life and free from the threats of discrimination and prejudice. Ladies and gentlemen, since 2020 until now, we are still in the grip of the COVID-19 pandemic, which is a new challenge for all of us who involved in the HIV response around the world, including Malaysia. This condition is due to limited and restricted mobility. Staff and the health facilities level are involved in the management of COVID-19 cases, and the period of starting ARV treatment takes a long time. It has been a direct impact on the community's effort to deliver the best services to the key population. In response to the COVID-19 challenges towards HIV prevention and management services, HIV outreach and prevention programs have shifted towards online and virtual platforms. Outreach workers are encouraged to reach out and interact with clients via social media, which includes supporting communities' mobilization and engagement by helping clients to continue accessing to HIV services. In the spirit of end inequalities and AIDS and pandemic, MAC is committed to intensify its programmatic and advocacy efforts to create an enabling environment for people living with and communities most affected by HIV. Leadership in the commitment to the multi-sectoral response to HIV will be strengthened among religious, political, and grassroots leaders alike, as well as other stakeholders, to reduce the negative impact that HIV and AIDS associated stigma and discrimination have brought about to the community members. In today's presentation, I will share some snapshots related to HIV and AIDS statistics and HIV programs undertaken by Malaysian AIDS Council and its partner organization and the HIV Care in Malaysia. Okay. So a bit of background. In 1992, established in 1992, the initiative of Malaysian Ministry of Health Malaysia. So this is the background of Malaysian AIDS Council. We were established in 1992 under the Ministry of Health. The function of Malaysian AIDS Council was to coordinates the activities and strengthens the capacity of non-governmental and civil society organizations that we call the partner organizations in the national HIV and AIDS response. So a total of 43 partner organizations till today. We started in 1992 with 7 founding members. Next slide. The vision of Malaysia's reaching zero through the fast tracking and ending AIDS vision: 0 new infections, 0 discrimination, 0 AIDS related death. So the goal of ending AIDS by 2030, which means 90% reduction of new HIV cases from 2010 based on AEM. So the targets: 95% of key population tested for HIV and know their results. 95% of people with diagnosed HIV receive anti-retroviral treatment. 95% of people on ART achieve viral suppression, and 90% of key populations are reached by combination prevention services. Next slide. The National Strategic Plan of Ending AIDS 2016-2030 we have 4 strategies to testing and treatment, improving the quality of coverage of prevention programs among key population, reduction of stigma and discrimination, and ensuring quality strategic information and its use by policymakers and planners through monitoring, evaluation, and research. Next slide. An overview of HIV epidemic in Malaysia. This is statistics from 2020. So you can see that total reported cases since 1986 till 2020, we have 125,000 plus. And HIV notification rate for 2020. So last year, 9.31 for every 100,000 people. Okay. New infection in women and girls in 2020 was 331. Total reported new infections in children below 13 was 15. Okay. Next slide. So the HIV cases in Malaysia are declining. We had a peak in 2002 where we had 6,978 reported cases, which was a 25.5 cases per 100,000 people. And we have achieved a 66% reduction. In 2020, we have 3,146, which is 9.31 cases per 100,000 people. Infection among people who inject drugs. In 2020, we had 122 cases, which is very much less compared to in 2002, where it took up 74.2% of the total HIV cases, which was 5,176 cases. Okay. Vertical transmission from mother to child was maintained at less than 2%. Next slide. HIV notification rate per year. If you see the graph, from year 2000 to year 2020, 21.74 has come down to 9.31. Okay, so we had a peak in 2002 and then it started declining and now it is at 9.31. So we are hoping this rate will keep reducing to a not significant figure. Next slide. HIV cases in 1986 to 2020. You can see in 1986 we detected first reported 3 cases of HIV. By 1998 we had 4,624 cases. In 2002 was our peak, and then 2006 down to 5,830, and in 2020 3,146. The next slide. HIV transmission by age group. Okay, so this is the statistics from year 2020. If you see, below 13 we have 1%, which I mentioned earlier, 13 cases. 4% in those between 13 and 19. 44% are teenagers, 20 to 29, and 32% are between the age of 30 to 39. And those 40 to 49, 12%, and above 57%. This I think most NGOs know that in the early days, there were a lot of involvement of NGOs in works in school. So a lot of programs were run in schools where we educate the younger generation on HIV and AIDS, on sexual reproductive health and rights. There were a lot of NGO involvement, but today the system is a bit different. I think MOE has taken the lead in handling schools, and I think MOH's involvement is also very much lesser compared to before. I think before we had ProStar, very famous in the 90s, program Sehat Tanpa AIDS untuk Remaja, very successful program. But now MOE has taken over, but we are still advocating and we are also pleading that we allow NGOs and also MOH to penetrate the education system, in which we are more involved in educating students, the young students, okay, the secondary school students, about sexual reproductive health and rights. This will help to sensitize them, make them understand, and probably it will help to reduce that 1% and 4% and even the 44% that we are looking at now. Okay, next one. HIV transmission by risk. In the 90s, I think the earlier days, injecting drug users were holding the higher number of HIV transmission. And today, we have turned the table around thanks to the needle exchange program that was launched by MOH many years back, which of course had a lot of initially negative feedback, taboo and all that, but it has successfully reduced the rates of HIV transmission in the country to now sitting at 4%. This is actually a tremendous achievement by our nation. And this exchange program is still going on with the help of AADK and all the involved organizations. And we are still trying to keep this rate as low as possible. 1% mother to child vertical transmission, so we are still below 2%, 1%. The highest rate of transmission today is sexual transmission. So a lot of awareness needs to go out to make people understand about HIV and its mode of transmission and how to prevent from contracting HIV. 1% for others, which includes blood transfusion, organ transplantation, needle stick injuries, and so on. Okay, next slide. So this is the graph of the transition that we've seen, comparing new infections by year from injecting drug users to sexually transmission, okay, from 2005 to 2020. So you can see the injecting drug user transmission, which is in dark blue, and sexual transmission is in green. From 4,000 over cases in 2005 has come down to 122 now, 2020. Whereas for sexual transmission, from 26%, 1,565 cases, now we are at 2,970 cases, which has become 94% of the total positive cases we detect. Okay, next slide. HIV transmission by sex, males and female, 99%. In 1990, 99% were males, 7% were females. In 2020, 89% are male and 11% female. Next slide. HIV testing and treatment cascade. So gap to reach the first 90, to detect the first 90 positive cases, we have to screen over 11,000 cases to be able to detect the first 90 positive cases. Okay, and for treatment, the first 90 who start treatment, 25,454 cases, and to reach the third 90, another 2,257 cases. Next slide. HIV prevention. I think we are harm reduction programs implemented by government agencies and non-governmental organizations since 2005. We are greater utilization of ARV drugs for people with HIV. In 2015, we only had 28% of positive people living with HIV on treatment, and today we have achieved 58% who are on treatment. We still have a long way to go. A lot of education is needed. We want to initiate HIV treatment as early as possible, immediately after detection. This will reduce the risk of disease progression. At the same time, it will reduce the risk of transmission. So this is our target. 58% is still better than before, but it's still not the target. We need to work harder on that. That's why the awareness program is very important. We are the implementation of the DHSKP, which is differentiated HIV services for key population. So there is a collaboration between the Ministry of Health and also non-governmental organizations. We work together to bring people from key population to come forward for testing and early treatment, counseling, testing, early treatment. So this program is a great initiative and a great collaboration, which has been very successful in many states. It is still ongoing. It's a transition program. So from NGOs, we combine together with MOH, with the clinic Kesihatan, and we're working very hard in achieving this. So we run prevention, testing, treatment, and care. All right. Strengthening the NGO-government partnership to achieve the UN AIDS 2030 agenda via the following initiatives. HIV self-testing. We are encouraging HIV self-testing. We want people to be aware of their self, and self-testing is a very important part. So we want to improve the sales and also the distribution of HIV test kits for people to test themselves, also through the NGOs, and broadening the health clinic model nationwide. Okay, the DHSKP program. Improving access to treatment of antiretroviral drugs. So the antiretroviral therapy, what does it do? Next slide. Antiretroviral therapy is the daily use of a combination of HIV medication to treat HIV. ART saves life but does not cure HIV. So it is not a cure, but is a viral suppressor. It can suppress your levels to an undetectable rate. Okay, so it reduces the amount of HIV in your body. It reduces the risk of HIV transmission. It prevents HIV from advancing to AIDS, and it protects the immune system. So this is what we want to achieve. So the target of ending AIDS includes reducing AIDS-related deaths. Next. The U equals to U concept. There is no risk of passing on HIV if your doctor has confirmed that you are undetectable or virally suppressed. You continue taking your treatment and attend regular viral load monitoring appointments. So the U equals to U is undetectable equals to untransmittable. Okay, next slide. Differentiated HIV services for key population. HIV prevention kit. We have condoms, we have lubricants, we have BCC focused on practice of safe sex. So we have behavior change and communication. That these are programs that we run for the key population for them to understand about HIV and sexually transmitted diseases. Referrals to HIV testing and counseling, community-based HIV screening. Referrals to STI testing, referrals to legal support services. So these are all part of the THSKP model. Next. Next. We've done that. Okay. So the challenges that we face: structural barriers in accessing HIV testing and STI screening. Health is not a main priority for key population. So key population need to be educated about health. Some don't understand the importance of them protecting themselves from STIs, and education is the only way. Some key population, I think we must understand that they are not very tech savvy. So we have our outreach staff that actually go out to the ground to speak to them, to educate them. So they play a very important role in this prevention program. So for them, when they go down on the ground and they look for key population and address this issue of sexually transmitted infections, only then they understand and they come forward for testing. So till that is achieved, it is very difficult. Not everyone is very tech savvy. Not everyone actually look out for what is HIV, what is STIs, and so on. Okay. Hidden female sex workers, MSM population, from street-based to online services. So now, because of the pandemic, a lot have moved to online base. So everything is on social media. We are trying to communicate with our clients. We are trying to communicate with key population through the online method, but it's not easy. So it still involves going down to the ground. It still involves going out to reach out to them. So these are major challenges that we are still facing, and we are trying to sort this out. And if you notice from the statistics, young teenagers, okay, above 13, are positive HIV. They actually don't have no clue about health. I mean, the awareness on their health is very minimal. So to catch them, to get hold of them and to educate them, it's not easy. It should be done at school level. Sometimes our outreach workers will go out to key locations, key areas, key locations in the country or in the state to look for them, to see whether they are out there, either on the streets or in red light areas, and trying to educate them. This is what we are doing till today. Okay, I think since the 90s we have been doing that. Now we are just advanced to a bit of online and social media, but this groundwork is still ongoing. ATS use and chemsex users. Okay, there's lack of special initiatives. So this is actually a current issue that's going on. and not only MAC, a lot of partner organizations are looking into how to handle chemsex issues and to prevent spread of HIV. Stigma and discrimination, also another problem that is going on. I think thanks to MOH is currently running a nationwide program. I think they are going to start, or they started, to tackle stigma and discrimination, especially among the Ministry of Health, which is a very good initiative. But the NGOs are also working very hard to kind of curb stigma and discrimination among our population. So people living with HIV are still feel very stigmatized. They're still feeling very discriminated in many ways. So a lot of people are not coming out. They don't want to reveal their status. They don't want to. Some people even don't want to test because they don't want to know. They don't want to be labeled. So this mindset needs to be changed, and a lot of hard work has to go out to actually sort this out. Engaging young key populations. So we want to engage. We want to get young people involved in these programs. It's not easy. To be frank, a lot of us, including Dr. Kenny, I think from very young age, were involved in sexual reproductive health work, including myself. I think umur 14 tahun dah join. I think Kenny pun around that age join sexual reproductive health work. And it's important to engage young people because we always say that peer-to-peer actually spread of information, correct information, is actually one of the key ways to disseminate the right information. And this peer-to-peer is actually a very important model, and I think it should be done. Not reaching, limited access to other sub-key populations like male sex worker and transgender men. So this is also another issue that they are facing. It's not easy to reach out to them, but a lot of male sex workers are on social platforms. So we are working hard in engaging with those online platform creators to actually find ways to engage, to get in touch with male sex workers, to promote HIV testing, the use of condoms, and so on and so forth. Next. So it's a cycle, all right? When you have stigma, it causes discrimination. When there's discrimination, it leads to violation of human rights. So it's actually a cycle. So if we curb stigma, we are able to curb discrimination and violation of human rights. Next. What we can do about stigma? An effective response to the HIV epidemic must tackle the root cause of stigma and ensure services are inclusive and accessible. So we need to include key population in the healthcare services design and implementation, stigma and discrimination reduction as a goal in its national strategies, and to educate, to address fear, to address attitude. We need to protect anti-discrimination laws, their discrimination and challenging violence. We have to empower every individual to understand the rights and to act on violations. Next. What we need to do to end stigma: we need to talk about HIV. We need to be open about it. we should normalize the topic of HIV. We need to correct misinterpretations and help others learn more about HIV. And we need to mind our language. We need to take action. Words are sharper than sword. Words are sharper than the sword. Okay, so words thrown to someone who is a PL-HIV, it's very, very demoralizing. It's very piercing to them. So we have to be very careful what we say, as action speaks louder than words, and it leads others to their supportive behavior. Moving forward, MAC's initiative. So what Malaysian AIDS Council have done, we have broken down to many technical working groups for every key population. This is to target specific problems in particular key populations. So these differentiated approaches and also differentiated approaches for ATS use. So we are trying to do mental health interventions to educate the younger generation who are involved in chemsex and the use of ATS to understand the implications of using them. Stigma and Discrimination Manual for healthcare workers. This is also being done. So there is a manual for healthcare workers to reduce stigma and discrimination. To include participation of young key populations into national state level meeting discussions and decision making process. So involvement of the young key populations are very, very important. As the trend are changing, I think new things are happening, and the younger generation are very innovative. They think of many new ideas, and I think their involvement are very important. It's very important in helping us tackle new scenarios and new situations. So it's always good to engage young key population. I think it's a very important way to curb this issue. Changing the outreach mode in reaching out to female sex workers and MSM. So we have a lot of social media platforms. We are engaging with a lot of social media platforms to actually promote HIV testing and use of condoms. I think we have engaged with Grindr and so on. These social media social media apps where use of condom is actually being promoted. So we promote the use of condoms so that they can stay safe. PrEP and PEP, pre-exposure prophylaxis and post-exposure prophylaxis. Still a lot of work needs to be done in educating the public on PrEP and PEP, where to access PrEP and PEP, and how to when they need to take it. So a lot of NGOs are going out and making people understand about PrEP and PEP. A lot of work is being done in social media and also on the ground to make people understand on PrEP and PEP. And once that rolls out very strongly, we can reduce HIV transmission. And also promoting HIV testing, self-testing. So we want more people to test, more people to be aware of their situation, more people to understand the importance of testing HIV if they are at high risk, and early detection, early treatment can save lives. So they need to understand that, and we need to educate them. Okay, so that's all with my slides. Thank you very much. Any questions on the A bit on PEP and PrEP. PEP and PrEP can be accessed through there is a HIV Connect app where there is a locator, and in that locator you're able to locate clinics or healthcare providers that actually provide services of PrEP and PEP in the country. So we are engaging with a lot of primary care clinics who can provide PrEP and PEP to our key population. So through the HIV Connect program or the HIV Connect app, I think they can locate. So that's something also needs to be highlighted. Pre-exposure prophylaxis and post-exposure prophylaxis. So there is if you are exposed or you're going to be exposed, then you can take the pre-exposure prophylaxis. It is something you take regularly to prevent yourself from contracting HIV. The post-exposure prophylaxis is actually if you had, example, one night stand situation where you didn't have a condom, you had unprotected sex, and you're worried that you might contract HIV. So within 72 hours, you need to get access to post-exposure prophylaxis, and you need to take it. So there's a regime to it. The doctors usually will advise on how you consume it, and if you take it on time, you can prevent yourself from contracting HIV. It's a bit costly. That is self-paying. I think it goes up to about 300 plus, if I'm not mistaken. Ada 300 lebih. 300 lebih kan the treatment for a 1 month course. Sorry, I didn't. At the moment for PrEP and PEP, there is no funding, and it's not provided by MOH yet, but there is an initiative that is ongoing. There's advocacy and initiative program that's ongoing to get MOH involved in PrEP and PEP in the clinic Kesihatan level. That's an ongoing program in process, but at the moment PrEP and PEP is self-paying, so people have to go to clinics that provide PrEP and PEP. And even the use of PrEP and PEP, the doctors who are prescribing PrEP and PEP actually have to go through a course to understand about pre-exposure prophylaxis and post-exposure prophylaxis, when they are allowed to give it, and so on. So there is a flow to it. So it's at the moment it is still self-paying. You can use the HIV Connect app. There is an app called HIV Connect. We are trying to promote this app as much as possible. The HIV Connect app actually has a locator that can help you identify clinics that are providing HIV treatment, care, and support in every state. And but the issue with this is it is on a voluntary basis. So clinics have to volunteer to provide these services. It is not something that we can force the private sector to come in and provide this service. So usually we encourage clinics, we encourage NGOs to go out to their partner clinics to actually get in touch and engage themselves in HIV Connect and go through the course, so they can start providing PrEP and PEP. That's the thing. At the moment, MOH is not providing this, so it's self-paying. That is why MOH is not providing yet. But there is there is ongoing discussions and advocacy programs to try to engage, get MOH to get involved in pre-exposure and post-exposure prophylaxis. But it's still an ongoing process. We have got no final word yet, but once that is done, then it becomes very much accessible for more people. But at the moment, it's still private clinic engagement. So we encourage all NGOs to actually get clinics involved in this program. Yeah, but once the primary care clinics they go through the course, they will also be very aware of how to treat this. Of course, there is HIV testing involved to ensure that they are negative, and then there is post-exposure treatment, pre-exposure treatment. I think in Klang Valley, a lot of clinics are involved, and even larger health institutions like are involved in this. So we have a lot of access in Klang Valley, but in other states, access are a bit limited, but we are encouraging. The reason why the course is important is because we need to make sure that there's a lot of stringent regulations to when to start, exact time to start. If they pass that duration, they cannot start. All that fine details are actually very important, and that is why we need to teach and educate even the healthcare staff who are involved in PrEP and PEP. Okay. Yeah.
The doctor will go ahead the cost of the lab, also the cost of the doctor looking at not with the patient, look at patient, so not 300. It's what is 300?
Yeah, I mean it's 300 plus, but the cost of the treatment itself is 300 plus. So there are some NGOs who are able to procure the drug through I think only one NGO, only Penang Fada, I think, is procuring it from and being able to prescribe it, but it's prescribed through doctors or ID physicians or those who come to our clinics. They're able to get it, but like how Doctor mentioned that the clinic Kesihatan are helping, because if they identify, they are prescribing it, but because they don't hold the drug, they are unable to provide the drug. So you need to actually collect this drug from you have to buy the drug from the clinics or the NGOs that are actually providing it, and that's the only way to get it is through that HIV Connect App. Drugs. Yes, amphetamines and all that, drugs. So people who take drugs and have casual sex, that's now it's chem sex. So that's the issue that we are going through now. So we are trying to curb that. Any questions? Okay, there's no questions. All right. So thank you very much.
That was Dr. Harry, ladies and gentlemen. He took us through the history of Malaysian AIDS Council, its vision and mission statements, and the strategic plan as well. And he was able to provide us an update on the number of cases as of date, the risk factors, mode of transmission, awareness, prevention, strategic plan, and treatment plan as well. Thanks for the undeductible, untransmissible concept, which was something different. And last, to finish off, he was able to share a lot of challenges that he has. Despite the challenges, it's good to hear the number of cases are going down. Thanks for that. Keep our fingers crossed that it's going to be the same. And it's good to hear as well that you have a strategic plan for the years to come by and they are well in place. Thank you very much. Give us a round of applause.
Thank you, Dr. Harry Dinesh, for the insightful talk. Now I would like to invite Dr. Naren to hand over a token of appreciation to Dr. Dinesh. Thank you, doctors. Now, there will be a video presentation by KLASS University medical students.
Acquired immunodeficiency syndrome, also known as AIDS, is caused by retrovirus known as the human immunodeficiency virus HIV. HIV continues to be a major global public health issue, having claimed 36.3 million lives so far. The clinical criteria for the diagnosis of AIDS are a positive test for HIV antibodies done by ELISA and/or a particle agglutination test, a positive supplementary test done at a reference center, and a CD4 T-cell lymphocyte count of less than 200 cells per cubic milliliter of blood.
Human immunodeficiency virus can be isolated from virtually all body fluids of HIV-infected persons, including blood, sweat, tears, saliva, semen, vaginal fluids, and breast milk.
Sexual transmission. The virus may be effectively transmitted from an infected person to his or her sexual partner, man to man, or woman to woman. Transmission between women has also been reported.
Parental transmission. This may occur in the following circumstances: transfusion of blood and blood-related products, sharing of contaminated needles and syringes, contaminated shafts or inoculation injuries, and residuals of body organs, semen, other body tissues from an HIV-infected donor.
Perinatal transmission. This is transmission from mother to child, which may occur during pregnancy, at delivery, or shortly after the birth. The risk of transmission perinatally has been reported to be between 20% to 40%.
Breast milk has been implicated as a mode of transmission, although reports still vary worldwide as to its effectiveness. In Malaysia, HIV-infected mothers are advised to refrain from breastfeeding, and alternative feeding supplements are advocated.
Most HIV-infected patients in the early stages are asymptomatic. With the progressive fall of the CD4 plus T lymphocyte count characteristic of the disease, various signs and symptoms will become more apparent.
As the CD4 T lymphocytes progressively declines, symptoms may appear. The commonest symptoms and signs that are encountered in the early stages are malaise, lethargy, loss of appetite, loss of weight, diarrhea, and also intermittent fever. Over time, the patient may develop progressive weight loss of more than 10% near ideal body weight, prolonged fever of more than 3 months, and persistent generalized infertility of more than 2 groups of 3 months.
Progression to AIDS can be predicted by doing certain laboratory tests during this phase. Laboratory abnormalities are leukopenia, reduced CD4 plus T lymphocyte count, decreased ratio of CD4 plus to CD8 plus, and raised gamma proteins.
Clinical management of HIV infection will depend on the stage at which the disease process has developed.
At the end of 2020, 680,000 people died from HIV-related causes and 1.5 million acquired HIV. There is no cure for HIV infection. However, with increasing access to effective HIV prevention, diagnosis, treatment and care, including for opportunity-filled infections, HIV infection has become a manageable chronic condition, enabling people living with HIV to lead a long and healthy lives.
get tested for HIV and get treated for STDs. Insist that your partners get tested and treated too. Having STD can increase your risk of getting HIV and or spreading it to others. Talk to your partner about HIV testing and get tested before you guys have sex.
Limit your number of sexual partners. The more partners you have, the more likely you are to have a partner with poorly controlled HIV or a partner with a sexually transmitted disease. Both of these factors can highly increase the risk of contracting HIV.
Talk to your healthcare providers about the pre-exposure prophylaxis. Pre-exposure prophylaxis is the HIV prevention options for people who do not have HIV but are at risk of getting HIV. Pre-exposure prophylaxis involves taking a specific HIV medicine every day to reduce the risk of getting HIV through sex or injection drug use.
Hello, my name is Dudi Hidayat. I am 21 years old. I am a caseworker for Kuala Lumpur AIDS Support Service Society KLASS, and I am also a person living with HIV, pure HIV. I was diagnosed with AIDS since I was 18 years old. I believe that was in 2018. But I had shown symptoms way back before. I believe when I was just 16 years old. But due of my age factor, due of MOH guidelines, I cannot go to clinic Kesihatan or any hospital to do my screening without bringing my guardian. So I had to wait until I turned 18, then I can go to testing. When I think 3 months prior after I turned 18, I went to KLASS to do my testing, and the result came out positive. On the same day I got my result in the KLASS, I immediately told my adopted auntie. I live with my adopted parents, adopted family. So, but I did told only my auntie on that time because I believe I have this closer bond between us, and I believe she's the one who, in all of my family members, she's the one who can understand the most. So I did disclose my status to her, and then we did talk. We did discuss whether we need to disclose this to others of my family, and actually we did only a week after I did disclose my status, and their reaction quite shocked, but they support me in any way. I believe that because they had already this knowledge about HIV, so I would say that I am quite lucky. If you ask me how does the virus impact my daily life, I would say, if me personally, when it comes to mentally, I would say that, the day I walked into KLASS, I eventually know that the result came out positive because of the symptoms that I've been showing in the past years. And I did my research early before I went to KLASS, so I would say that I am mentally prepared. But when it comes to my physical body, oh my god, I would say that it was a drastic change. I'm getting thinner. I lost so much weight, and then I consistently lost out of breath. Even though I don't do anything, I will easily get tired. Even though I just stayed in my bed the whole day, I will easily get tired. So I would say that did change rapidly. But when it comes to my family, we got closer because they supported me. So the relationship between me and my family is getting closer. Is getting how to say, the strength of our relationship getting solid. Not only with my family but also my friends. They understand me, and they would say, like, you know what, Dodi, let's just fight this together. We can do this together. So I would say I'm quite lucky when it comes to support system. But when it comes to job occupation or job opportunities, I would say that I'm very unlucky. I still remember the first year I had to change more than 5 jobs because of I would say not. I don't want to say it's stigma. I do understand that they don't have the knowledge in HIV AIDS. But yeah, I had to go consistently to clinic for the first 6 months, take blood and so on. So I had to take medical leave often. So they will always ask me. So I had to disclose, and once I disclose, they will terminate me. So yeah, I would say that when it comes to job opportunities or even occupation, I would say I'm lucky. Up until I joined KLASS, and there's the moment that I believe that, you know what, this is my place, this is where I belong. So until today, I'm with KLASS, and I'm very grateful for. I would say, if it's not because of I've been jumping jobs before I I know KLASS, I would not be here today. So yeah. So what is basically HIV? HIV stands for Human Immunodeficiency Virus, where it's a virus that attacks the immune system. And once it attacks your immune system, and if you did not get treated as soon as possible, it leads to AIDS. Now, what is AIDS? AIDS is acquired immunodeficiency symptom, where is a stage once your CD4 count is below 200. Now, what is CD4? CD4, known as T cells, is actually your white blood cell in your immune system that fight any infection. And it's also an important role in your immune system. So, how do I explain this? Consider your CD4 as a barrier or as a shield to protect yourself from any kind of infection. Now, what the HIV virus do, they will go deep in your immune system and they will eat your shield and your barrier. Once they do that, you will expose with any kind of threat or any kind of infection due off, because there is no longer barrier or any shield to protect you. So that is actually what is the HIV virus do. If you ask me about stigma, obviously I had it. I believe that I have been harassed and stigmatized since the first day I've diagnosed. And up until today, I still receive such threats and such stigma, not only in my previous workplace, but also in public. And also, I believe not majority, but some healthcare, which is hospital and clinics. But I'm not gonna blame them, because I'm not gonna say it's normal, but I do believe that I do understand that they still do not receive such knowledge about HIV and AIDS, because it's such a taboo subject and we not often talk in our daily life. So, but I do hope that one day this kind of stigma, that's been still ongoing, has to put an end. I would say that people need to be open-minded and more accepting. If there's one message that I could convey to others about this stigma that has been going on, I would say that for those who don't really know, people living with HIV, if they follow accordingly with the treatments, if they follow accordingly with the doctor's guideline, they could actually achieve undetected virus to UVL. How we say it? Basically, what is UVL is where there's a state where the virus inside the immune system has been suppressed due of the treatment, and up until the virus cannot be infected to others, even though the individual had an sexual intercourse without protection. So basically, like I myself already UVL undetected. So if I get married, my wife and my kids will not get infected with the virus because of the virus is so suppressed due of the treatment. So what I'm trying to say here is that the treatment is available and the treatment actually is working. So basically, we are normal and you should not be afraid. So I hope with this you guys could, more understanding and end the stigma.
Alright. Now, a reminder to our participants again, please remember to mute your microphones during the presentation. Moving right along, we will now have the forum. It is now my pleasure to introduce the moderator for this forum and the three panelists who will be joining us today. Our moderator for today will be Mr. Jeremy Tan. He is currently pursuing his bachelor's degree in psychology at University Tunku Abdul Rahman. At the same time, he is also a program and project officer at the Federation of Reproductive Health Associations Malaysia. He was a member of Technical Working Group for Malaysia, MSM Network, and National HIV Response, Malaysian AIDS Council, a youth delegate at Asia Pacific AIDS and Co-Infections Conference in Hong Kong, China, and was also awarded the completion of training of trainer as mentor for it as well. He has strived to bring awareness regarding HIV in various ways, and we are truly proud of his hard work and dedication. Our first panelist for today is Dr. A. Vigneswari. She is a family medicine specialist and obtained her master's in University Malaya, Malaysia, and she is currently working in Clinic Kesihatan, Taman Medan. Next, we have Puan Siti Marlarita. She is currently a program coordinator in Persatuan Insaf Murni, Malaysia. She was an outreach worker with FSW program at Federation Reproductive Health Associations Malaysia, FRAM and PKKUM. Was also a peer coach at the National Anti-Drug Agency. And we have Ms. Moon. who has been living with HIV for the past 15 years and is receiving heart treatment, and she's in UBL status for the past 10 years. She's currently an outreach field worker staff and program coordinator in Kuala Lumpur AIDS Support Services Society, KLASS. She's also involved in the peer support program in Hospital Kajang and KLASS. Over to you.
So, Assalamualaikum, selamat sejahtera and good afternoon to everyone. So welcome to the live forum of today, the World AIDS Day, the live forum. So today we are very lucky to invite three very wonderful panelists yang mempunyai banyak pengalaman dan juga pandangan dalam bidang kerja HIV ini. So untuk sesi forum pada hari ini akan mengambil masa kira-kira lebih 30 ke 40 minit. Dan sebelum kita start, pusingan live forum pada hari ini akan dibahagi ke dalam 3 bahagian pusingan perbincangan. Di mana pusingan pertama, kita akan memahami daripada para panelis apakah status HIV sekarang di Malaysia. Dan untuk pusingan kedua, kita akan dengar daripada pengalaman mereka, pandangan mereka tentang melalui khidmat mereka sebagai outreach worker atau sebagai doktor, apa yang kita boleh buat dalam masa yang akan datang. Dan untuk pusingan ketiga, kita akan together explore potensi-potensi solution atau intervensi yang kita boleh apply di Malaysia untuk mengurangkan cases HIV yang pada masa akan datang. So tanpa memanjangkan masa lagi, saya ingin menjemput para panelis untuk memperkenalkan diri, nama anda, organisasi anda dan sedikit tentang diri anda. So mungkin kita boleh start dengan Dr. Vicky dulu.
Thank you, Jeremy. Selamat pagi, petang, tengah hari everyone. Saya Dr. Vicky, saya seorang pakar perubatan keluarga. Saya tugas di Klinik Kesihatan Taman Medan dan saya telah involved dalam management patient HIV daripada time saya MO Junior in the 1990s dengan Dr. Christopher Lee di HKL sampai ke sekarang.
Terima kasih, Doktor.
Assalamualaikum, selamat tengah hari. Saya Mun, saya orang yang hidup dengan varian HIV. Started rawatan HAD 2004 sampai sekarang masih lagi first line and then undetectable virus mostly 10 tahun. Saya bertugas di Kuala Lumpur as support services and then saya peer support di hospital Kajang dan menjaga klinik kesihatan Bandar Baru Bangi.
Terima kasih.
Okay, Assalamualaikum dan salam sejahtera semua. Boleh panggil saya dengan nama Kak Ita. Okay, saya seorang PL HIV yang dah 18 tahun. Okay, I diagnosed daripada tahun 2003. So, mulakan rawatan HAD pada tahun 2017. Dan saya ada 2 orang anak lelaki yang sihat, alhamdulillah. So sekarang I bekerja, sebelum dia I bekerja sebagai outreach worker dekat PTUF. Lepas tu dekat FRHAM dan sekarang I program coordinator dekat Persatuan Insaf di Malaysia sebagai untuk program PWID dan PWID.
Terima kasih kepada para panelis untuk memperkenalkan diri mereka. So kita akan start dengan sesi pusingan pertama. So soalan pertama adalah kepada Dr. Vicky, sebab dalam tahun 1986 Malaysia kita detect atau temui kes HIV yang pertama dan sampai sekarang sudah lebih kurang 35 tahun virus tersebut ada di sekeliling masyarakat kami. So mengikut pengalaman doktor, adakah kes HIV masih meningkat sampai sekarang atau sudah sampai satu tahap yang kes sudah menurun?
Okay, so like I said, saya pun dah kerja dengan HIV for 30 years and memang ada banyak perubahan dalam senario HIV di Malaysia. Macam first presenter tadi, masa saya start kerja, it was mostly IBDU. About 80% of patients daripada golongan IBDU, daripada golongan seks 10-20%, dan from the golongan seks pun, yang heterosexual was most of it. Kalau MSM 1 ke 2% sahaja. Tapi now is totally different. IBDU maybe 15 to 20%, less than that actually. Sexual exposure is the main driver of the virus now, and most of the cases that we see now are MSM. In fact, in my clinic, I think dalam the last 2-3 years, kebanyakan kes baru yang saya tengok adalah young adult males yang dapat melalui MSM. So that's a big difference in the type of cases. Kita juga tengok sekarang HIV, scenario HIV sekarang. Kalau dulu bila you kena HIV is macam life sentence because there wasn't much treatment. And it's very hard to get treatment. Kena pergi jauh ke 2 or 3 major hospital kat KL di Malaysia je yang ada treatment, tak ada dekat kita kan. Tapi sekarang, treatment boleh diperoleh di mana-mana, kebanyakan klinik kesihatan di seluruh Malaysia. So you tak payah pergi jauh-jauh ke daripada JB ke KL, dari Kuala ke KL. You just go to the nearest clinic dekat your house. And the third thing also is that treatment is much more simple sekarang. Dulu kan ubat pun tak optimal, 1-2 jenis saja, tak adalah hard ke apa-apa macam tu. And treatment tu macam sangat susah nak makan. You kena, ada yang kena simpan dalam peti ais, ada yang kena simpan luar, ada kena makan sebelum makan, selepas makan, ada pil besar macam ni yang you kena hancur and kunyah. So it's so difficult for the patient. I kesian bila makan tapi tengok aku tak boleh makan macam ni. Okay, and now it's simple. 1-2 biji sekali sehari. Senang sahaja. So simple. And the best news of course is dulu is mahal. Okay, in 1990s, 1 bulan 1,500 ke 2,000 ringgit. So that's big money in those days. I mean, now also big money lah, tapi dulu even worse kan. So I remember dekat klinik Dr. Christopher Lee, bila patient datang, dulu selalu patient datang lambat dalam peringkat AIDS. Memang sakit tenat, memang tak boleh bekerja. So tak ada duit nak beli ubat. So kita akan ada family conference. Kita panggil ahli keluarga patient yang dah tahu status patient lah. So kita kata, he will tell them, okay, your uncle ke, your father ke, your brother ni sakit AIDS. Dia tak boleh kerja, tapi dia perlu rawatan. So you all kena bayar untuk dia. Dan dia akan tanya, okay, you boleh bagi berapa sebulan? You boleh bagi berapa sebulan? So we will have a rundingan, and then this family member will say, okay, I can give 100 a month. Somebody will say, I can give 500 a month. So kita paksa mereka janji, dan mereka akan bayar untuk kesakitan untuk 2-3 bulan. Hopefully by then patient dah okay sikit, dah boleh bekerja. Kalau tak, call lagi sekali untuk paksa mereka lagi sekali. So we do that for the patient. So the clinic was like an Along clinic, bukan klinik ID, klinik Along. Tapi now, free. First line is free. And it's near you, so it's so different the scenario now.
Seperti macam doktor kata, dengan kemajuan medication dan juga medicine, kita dapat menggunakan beban kepada mereka yang hidup dengan HIV. So soalan saya seterusnya adalah kepada Cik Moon, bila kita bincang pasal HIV, adakah HIV ni risiko kepada semua orang sama? Atau ada golongan-golongan komuniti yang berisiko lebih tinggi? Siapakah mereka dan kenapa mereka berisiko tinggi?
Okey, kalau nak ditanyakan pengalaman, jadi sebenarnya semua orang berisiko tinggi. Lepas tu, kalau nak dikatakan orang cakap HIV sebenarnya dari pandangan saya sendirilah. Kalau tak ada program yang macam untuk key population, sebenarnya semua masyarakat berisiko tinggi. Tak kira MSM, sex workers, dan Moon sendiri adalah pekerja seks. Zaman Moon dulu memang tak ada orang nak bagi tahu pun tentang safety, penggunaan kondom. Kita punya bapa ayam dulu dia cuma fikir dia punya KPI dia RM6. You boleh bagi dia untung, you boleh duduk tempat dia. Kalau you tak boleh bagi dia untung, zaman tu memang tak ada orang yang nak. Kalau you pakai kondom, tak ada orang nak ambil you. Tak ada orang nak zaman tu. Memang you kurang pendapatan. Tapi kalau you tak pakai kondom, memang you satu hari you boleh dapat 20 kong. 20 kong mean 20 orang. 20 orang tak lama je, 5 minit je settle. Dalam 20 orang, seorang 5 minit, itu zaman saya dulu. And then kalau dipikirkan tentang MSM, jadi sebenarnya sebab itulah beruntungnya kita dekat Malaysia sebab berbagai program. Yang pertama pada tahun 2013, kalau tak salah ingat saya, first program adalah Orange Focus. Orange program adalah program yang mendekatkan kepada komuniti tentang penggunaan kondom. Lepas tu kita ada program pertukaran jarum pada zaman tu. Alhamdulillah sampai sekarang ni, tetapi dengan malangnya komuniti yang saya rasa yang berisiko adalah komuniti yang tak ada kumpulan sokong bantu seperti cisgender, ibu kat rumah. Diorang tak ada community support group macam MSM, dia ada community support group untuk diorang sendiri dapat informasi yang tepat. Lepas tu female sex workers, dia ada community dia sendiri untuk bagi empower dia orang macam mana penggunaan kondom yang betul. Macam community PLHIV, dia ada support group dia orang sendiri setiap bulan. Memang setiap bulan ada sebab tu KPI. Lepas tu yang malangnya community yang tak ada pendedahan macam dia anggap normal, tetapi dia orang terpinggir, dia orang tak perasan, dia orang terpinggir sebenarnya. Dia orang tak ada kumpulan sokong bantu, dia orang tak ada informasi yang tepat, dia orang cuma dengar je tapi tak tahu sahih ke tidak, tepat ke tidak. Tapi kalau komuniti yang macam komuniti high risky population yang dia orang cakap, komuniti kekunci, dia orang semua empowered. So far alhamdulillah, apa yang Mun dapat tahu tahun ni dalam 300 orang PLHIV yang baru diagnose, seorang sahaja dalam komuniti itu adalah female sex workers, yang lain bukan. Yang mengejut tak data macam tu. Betapa empowerednya diorang, and then betapa ada kesedarannya diorang apa pentingnya pakai kondom. Kalau berbanding zaman Mun dulu, kalau disaring 10 komuniti tu, saya rasa 7 mesti ada, 3 je yang tak ada. Kalau zaman saya dululah. Sebab memang zaman-zaman dulu memang susah nak bagi pendedahan, nak bercerita tentang keselamatan ni memang payah. Tapi kalau boleh dari rumah kita dah cerita benda ni. Dari rumah, sebab kita cerita tentang orang cakap risiko ni, sebenarnya kita cerita tentang keselamatan. Macam mana kalau jumpa orang tu, apa kau kena buat? Macam ibu-ibu lah, actually ibu-ibu sebenarnya kalau ada anak perempuan, kalau anak perempuan dia jenis yang suka main keluar, dia akan bagi satu benda, maybe whistle, dia gantung kat leher. Kalau ada orang kacau kau tiup benda ni kuat-kuat. Macam tu lah kita untuk mengingati diorang. Kita bukan nak mengajar sebenarnya. Actually macam Mun sendiri, Mun tak ada pendidikan tinggi pun, Mun sekolah rendah je. Tapi disebabkan fikir benda ni setiap tahun, setiap hari duk fikir, akhirnya kita macam dah dari My Life My Story pun Mun dah bagi tahu. Kalau boleh benda ni dari rumah kita dah bercerita tentang seks selamat. Macam mana nak mengadakan seks selamat, seks yang betul. Bukan kita nak mengajar dia cara buat seks, tak. Seks yang betul, protect diri sendiri. Itu sebenarnya.
Okay. Terima kasih kamu untuk berkongsi sedikit tentang diri dia juga, dan kita terima kasih atas perkongsian tersebut. So, I nak sambung balik apa yang tadi Cik Mun ada sentuh sedikit pasal ibu atau wanita yang hidup dengan HIV. Sebab kadang-kadang di masyarakat Malaysia, bila kita bincang pasal komuniti beresiko, kita terlupa tentang wanita-wanita atau ibu-ibu yang hidup dengan HIV. So dengan pengalaman Cik Siti Malarita atau Kak Ita sebagai seorang wanita yang hidup dengan HIV, adakah anda rasa kerajaan Malaysia atau sistem kesihatan Malaysia telah buat yang terbaik atau bergiat usaha dalam penularan tersebut?
Okay, yes, betul. Sebenarnya Malaysia adalah salah satu negara yang dah berjaya, doktor. Sebab kadar jangkitan mother to child pun dah 1% tak silap saya. So macam saya sendiri pun, anak saya dua-dua sihat alhamdulillah. Dan kata saya memang sangat-sangat memberansak seronok lah, kita seronok kan bila benda-benda macam ni jadi macam masyarakat pun dah ambil tahu benda-benda macam ni. Lepas tu untuk golongan ibu-ibu PLHIV mungkin sebenarnya tak ramai wanita yang berani ke depan untuk bagi tahu aku adalah HIV. Seorang wanita yang hidup dengan HIV tak ramai sebenarnya. Sebab kerana diorang ni takut, diorang bukan takut apa. First kali ialah stigma. Dan stigma, selepas tu dia punya stigma. Adakah saya boleh berada di kalangan orang ramai? Bolehkah saya berada di sebelah orang? Bolehkah orang menyentuh saya? Kan? So bila benda-benda macam tu dia akan rasa dia kedil, dia hina. I bangga sebenarnya I seorang rakyat Malaysia walaupun I PLH lagi, tapi I masih berada dalam kalangan orang ramai hidup bebas dengan orang kata keluarga yang sihat, hidup yang sihat, keluarga yang sihat.
Okay, terima kasih kepada dua-dua panelis yang sudi berkongsi kisah peribadi mereka dan kami memang appreciate lah atas perkongsian tersebut. So sekarang kami akan continue dan sambung dengan sesi pusingan kedua perbincangan di mana saya ingin tanya Dr. Vicky. Sebagai seorang healthcare provider, mesti doktor banyak bagi rawatan kepada komuniti yang hidup dengan HIV atau yang berisiko tinggi. Daripada pengalaman doktor sepanjang ini, apakah cabaran doktor bekerjasama dengan komuniti tersebut?
Okay, so kalau kita ikutkan komuniti yang berisiko, one of the cabaran saya rasa is that they come forward untuk testing. Mereka tak nak datang untuk testing. Mereka yang dah ada contact dengan NGO, dengan peer support, okay, mereka akan bawa. So we still have peer supporters bawa mereka tiap-tiap minggu kita bagi special day, dia bawa a few to the clinic. So dia familiarize orang tu dengan klinik. So patient-patient kita dah familiar dengan klinik, tak takut sangat. Tapi masih ramai kat luar sana yang belum ada the linkage. So bila linkage tak ada, mereka tak nak datang ke klinik. So mereka takut stigma and discrimination. So kat sini saya kena memang kata lah MOH sedar pasal benda ni. Mereka sedar that there is stigma and discrimination among the healthcare workers yang sepatutnya tidak berlaku, dan saya amat rasa sangat malu dan sangat sedih bila saya dengar my staff ke somebody staff pun buat sesuatu yang tak bagus untuk patient, because it shouldn't happen anymore. It's such an old disease, we shouldn't be behaving like this. Tapi MOH memang dah buat banyak langkah-langkah, banyak training and stuff like that to make sure that kita punya healthcare worker ni terima semua orang macam orang biasa, because we all are the same. So one of the things kita engage dengan NGOs, and NGOs like my clinic, we are considered what we try to set up STI client friendly clinic. STI is sexually transmitted infection, so we have STI client friendly clinics. So kita engage dengan NGOs, they come to our clinics, they get to know our staff, they mengenali staff kita mengenali mereka, dan tengok oh mereka bersama dengan kita juga. So bila klien datang daripada golongan tu, mereka dah biasa dengan orang macam ni. Simple example macam the transgender group, they come to the clinic with a male IC, tapi mereka berpakaian berkebaya ke kurung ke rambut panjang, very lovely ladies. So bila dia register, dia memang kena guna IC lelaki. Dan sebelum ini bila kita tak kesedaran, my staff will call, okay Cik Ali loudly, okay, in front of all the patients. So of course Cik Ali tak nak bangun sebab Cik Ali pakai baju kurung dengan rambut panjang. So now we dah ajar staff, bila patient datang macam ni, tanya kat dia quietly kat depan tu, nak dipanggil apa ya? So the patient might say, saya nak Sarah. So so we catat dekat dia punya card ke, dia punya nota ke whatever, this is Miss Sarah. So wherever they go in the clinic, kita akan panggil Miss Sarah. So Miss Sarah akan bangun datang. So it's a small thing for us, but it's a very big thing for the community, and they feel happy that they can be treated with respect, and they are more happy to come forward. So kalau datang ke hadapan, we can screen and we can treat. The other aspect yang kita rasa a bit susah is because they're from the marginalized group, kadang-kadang susah untuk mereka mengikut rawatan. Sebab HIV ni sebenarnya kalau kita dah treat dengan betul, dia dah jadi macam chronic disease biasa, macam penyakit macam diabetes. You makan ubat betul-betul, you jaga cara hidup sihat, you akan sihat dan hidup lama. HIV pun dah sama macam tu sekarang, tapi you kena makan ubat tepat pada masa. Macam diabetes semua, kalau you tak makan ubat, you leka, you lupa sebulan ke 2 minggu ke apa, gula naik. Tapi kalau you datang balik, you start balik makan ubat, your diabetes will be controlled. Dengan HIV tak macam tu, you kena makan hari-hari pada masa yang sama. So kalau kita daripada golongan yang terpinggir, yang mungkin kerja malam-malam atau kerja dengan masa yang tak tetap, agak susah mereka nak ikut timing untuk makan ubat. So that is another problem we can face lah. And the other problem is, actually, we just have to tell patient, kalau you makan ubat dengan okay, you practice healthy behavior, healthy sex, safe sex, it's much easier to control your penyakit daripada you nak control diabetes. Because diabetes, selain daripada makan ubat, you kena jaga healthy diet. Kita orang Malaysia ni nak stop makan nasi lemak, mi goreng mamak, tarik susah kan. Hari-hari saya cakap dengan makcik-pakcik saya, patient saya, tak boleh makan, kena makan sayur, jangan makan nasi banyak. Tak boleh ubah sebab kita dah biasa. Orang Malaysia tak suka exercise kan. Kalau parking dekat shopping mall, pusing sampai dapat dekat dengan gate. Yes. So it's more difficult to change your lifestyle, eating habits, exercise habit daripada nak tukar your sexual habit. Just pakai lah kondom je, senang je. Kalau you're having sex with unknown people, then you must make sure that both partners are protected. Kalau boleh, you avoid unsafe sex. That's easier, I think, than changing tingkah laku. So those are the challenges we face among our patients.
Okay. Thank you Doktor, kongsi sedikit tentang pengalaman dia sebagai healthcare provider dan macam mana dari pihak hospital atau klinik kesihatan cuba upaya mereka untuk cater to the needs and wants of the community on the ground. So soalan I seterusnya adalah kepada Cik Moon. Sebab tadi kan kita tengok daripada segi kesihatan, pakar perubatan. So kalau di dalam konteks pekerja peer worker di NGO, apakah organisasi anda dan juga diri anda cuba untuk menangani isu-isu komuniti yang anda sedang bertugas atau berkhidmat?
Okey, saya boleh dikatakan beruntung lah sebab saya dari tahun 2013 saya bekerja dengan Pertubuhan Advokasi Masyarakat Terpinggir PAM. Masa tu saya masih bersama dengan komuniti SW program, and then di zaman tu kita banyak encourage komuniti supaya mengguna kondom, yang menjalankan saringan kesihatan di klinik. Apabila saya tahun 2019 saya bermula dengan kelas, saya amat beruntunglah dapat organisasi yang cukup berpengalaman di Malaysia dan berpengaruh. Dari 2001 lagi kelas telah ditubuhkan. Kuala Lumpur Support Services memang tak berhenti empower komuniti yang hidup dengan HIV dan AIDS. Mereka selalu membetulkan stigma, membetulkan tentang, orang cakap tentang mitos orang HIV, orang AIDS. Kalau nyamuk gigit boleh transfer, itu mitos semua tu kalau saya berkongsi minum bolehkah saya dijangkiti, itu mitos. Lepas tu kalau saya berpelukan bolehkah saya dijangkiti, kalau berkongsi towel, berkongsi bilik mandi. Sebenarnya kerja kita orang ni macam peer ni lebih kepada menerangkan dan memberi kekuatan dalaman kepada diorang supaya diorang boleh come out untuk bercerita dengan family diorang, family members diorang. Dari step itu dia boleh keluar daripada zon selesa dia, kompong selesa dia tu. Apabila dia dah keluar dari kompong selesa dia, dia akan boleh terus macam orang lain, and then dia akan boleh hebat macam kita orang juga. Itulah cabaran kita orang peer di hospital dan di klinik kesihatan. Nak memastikan diorang ni patuh dengan rawatan adalah satu cabaran yang amat besar. Sebab kebanyakan komuniti apabila dia makan tenofim dengan ifaviren, dia takkan faham kalau dia tak ada peer support, dia sendiri akan berhenti. Sedangkan rawatan ARV dia tak boleh berhenti simply suka-suka dia. Dia kena ikut nasihat doktor. Walau bagaimanapun, tapi apabila diorang tak faham, diorang tak ada rakan sokong bantu ataupun keluarga menyokong mereka, dia akan berhenti. Kat situ adalah satu cabaran bagi pihak kesihatan balik, FMS ke, di mana dia buat rawatan. Kat situ dia akan menghadapi satu lagi bebanan, iaitu kewangan untuk start second line. Banyak cabaran juga kalau kerja macam kita orang ni. And then Kuala Lumpur Support Services memang dia tak pernah jemu sampai sekarang. Kita memang selalu buat program melalui platform. Lepas tu untuk memperjuangkan stigma dan diskriminasi, kita banyak buat talk dengan swasta, pekerja-pekerja swasta. Kita dapat undangan. And then macam saya sendiri, saya bekerja di hospital, saya banyak task dengan staff-staff yang berdekatan. Ini saya bagi tahu apa yang tak betul, saya akan direct bagi tahu. Ini kita di klinik akan ada, saya nak cakap, lepas permulaan klinik, penutupan klinik, kita akan briefing di klinik, ID klinik Hospital Kajang. Setiap kali kita akan briefing apa benda yang tak boleh, macam mana mistik tadi, kenapa berlaku mistik tadi. Kita akan briefing, kita akan cari solution hari itu juga. walaupun ambil masa doktor pakar dari hospital Sungai Buloh. Itulah dia.
Okey, terima kasih Cik Mun kongsi dengan kita apa yang kelas sedang buat dan macam mana mereka sebagai peer worker approach community yang hidup dengan HIV atau berkenaan. So seperti yang tadi Kak Ita telah kongsi mengenai wanita banyak stigma dan diskriminasi tentang diri mereka. Dan kita tahu masyarakat Malaysia kan banyak netizen kita sangka buruk tentang mereka wanita yang hidup dengan HIV. Apakah kesan-kesan semua stigma dan pandangan serong sebut ini terhadap wanita yang hidup dengan HIV?
Saya suka soalan ni sebenarnya. Okey. Bila wanita, orang nampak wanita, orang tahu wanita ni ada HIV. Pandangan yang pertama sekali ialah perempuan ni jahat. Perempuan ni dulu cari makan. Sorry to say, pelacur. Perempuan ni dulu suka tukar-tukar jantan. Sebenarnya itu adalah salah satu kita punya mind kita, masyarakat lah. Masyarakat. Bila perempuan jahat je, oh HIV. Perempuan HIV je, jahat. Actually, ini daripada pengalaman I sendiri. I sebenarnya I bukan kaki jantan. Tapi I seorang penagih dadah. Dan I menggunakan jarum suntikan. Dan daripada jarum suntikan itulah virus HIV masuk dalam diri I. Okay. First. Satu lagi, bila ada orang mengatakan perempuan HIV ni dulu dia jahat apa semua, I tak boleh nak terima benda-benda macam ni. Adakah masyarakat tahu ibu-ibu yang PL HIV yang berada di rumah, yang tiada sokongan bantu, yang tak ada sokong bantu, yang tak tahu apa-apa pasal HIV, duduk di rumah bekerja menjahit, jadi suri rumah, suami yang keluar bekerja, suami yang bawa balik virus. Pernah ke masyarakat tahu benda-benda ni? Tak ada. Masyarakat tak ambil tahu pun benda-benda macam ni. Apa yang masyarakat tahu, tuding jari kepada wanita. Saya sebagai seorang wanita, ibu PL HIV yang sudah hampir 20 tahun, saya sangat-sangat terkesan dengan benda-benda macam ni. Walaupun saya dulu bukan seorang pelacur, saya bukan seorang kaki jantan ke apa, saya sendiri, suami saya sekarang tak ada HIV. Saya seorang HIV. Sebab saya seronok berkongsi dengan orang. Maaf, saya agak beremosi sedikit lah kan. Saya seronok bercerita dengan orang cakap HIV ni kata bukan suka-suka untuk orang nak bercakap. Suka-suka nak cakap, berstigma, diskriminasi. Sebenarnya benda tu tolonglah please open your mind. Buka minda. HIV ni bukanlah bahaya. Yes, betul bahaya, tetapi benda ni bukanlah satu macam COVID lah kita kata kan. Bila you kena virus tu je, you boleh mati. No. Kenapa I dah hampir 20 tahun I masih hidup? Anak I dua-dua sihat. Suami I sihat. I tak menjangkiti anak I tak menjangkiti suami I. 2 orang suami I sebelum ni tak ada HIV. Termasuk yang sekarang ni. Kesilapan I cuma I menagih dadah, I berkongsi jarum. Itu kesilapan I. So, I tak kisah orang nak cakap I apa. I seorang yang jadi tak ada perasaan. You nak cakap I penagih dadah apa semua, itu you punya pasal lah. Hak masyarakat nak bercakap, you punya pasal. Tetapi please, hentikan stigma kepada wanita PL HIV, mengatakan wanita HIV adalah seorang perempuan yang jahat. Stop. Please stop it.
Kita bagi tepukan kepada Kak Ita dengan keberanian dia berkongsi dia punya story dan juga apa sebenarnya isi hati atau the inner feeling of her.
Sebab I tahu doktor, sebab kita sebenarnya dekat Malaysia ni sangat ramai ibu-ibu PL HIV yang tak berani nak kat depan, nak pergi ke klinik, nak buat rawatan apa semua, dia orang takut. Sebab apa? Sebab masyarakat kita lah. Di klinik kesihatan sendiri pun ada stigma.
Betul Kak, I think that is why FRHAM ini bagi kita satu peluang yang sangat bagus untuk memahami situation yang sebenarnya community sedang facing. So kita ambil iktibar daripada insiden akak dan juga mungkin banyak-banyak lagi wanita yang di luar yang masih lagi bawa stigma, masih lagi di pandang serong daripada society. Sebab itu kita sekarang nak cuba cari apakah potensi solusi yang kita boleh implement atau dijalani di masyarakat Malaysia supaya kita boleh menangani isu-isu tersebut. So seperti data yang berdasarkan statistik yang diberi daripada Kementerian Kesihatan, kita tahu lebih ramai golongan kes HIV yang baru adalah golongan muda dan belia, remaja. So kalau dari segi pendidikan, adakah para panelis rasa pendidikan sexual di sekolah, sex education atau comprehensive sex education adalah antara satu cara untuk kita menangani isu tersebut di kalangan remaja? So mungkin kita boleh start dengan Dr. Vicky dulu, jika Dr. Vicky ada any thought on it.
Definitely kita kena ada proper sex education starting from even primary schools. If we don't do it, we're not going to stop it. In my clinic dekat Taman Medan, kita dah buat banyak untuk beberapa tahun, 4-5 tahun. Kita setiap tahun akan turun ke sekolah, 2 sekolah rendah dekat klinik kita. Of course, these last 2 years COVID tak buat lah ya. But before that, we do programs with the standard 6-12-year-old students. Kita cakap pasal dadah, kita cakap pasal HIV and all that. But what we dapat daripada student tu yang paling menakutkan. Daripada budak-budak lelaki, murid-murid lelaki yang umur 12 tahun, bila kita survey mereka, we have a very good peer support, public health person, he's a peer supporter, I guess you call her. Dia tahu macam mana nak dapat the truth from the children. So she gives them a safe space. Mereka semua dipakai blindfold, so dia tak dapat siapa-siapa, dan dia akan tanya soalan-soalan apa tingkah laku mereka. Dan daripada itu kita dapat tahu almost more than 90% of the budak lelaki 12 tahun dah melayari porn. Mereka kerap tengok porn dekat rumah dengan abang-abang adik, abang adik, abang, uncle, pak, ayah. So they already exposed to porn. So what's there to talk about sex education? We don't teach the right thing. Okay. Then kita expanded our program. Kita pergi ke sekolah menengah pula untuk Form 1, Form 2 students. We call that program Ribut Remaja, and we also did the same thing with them. And that's even more scary sebab kat sana ramai gadis-gadis 13-14 tahun dah experience in sex. Some, yes, telah dirogol oleh family members and things like that. So those we refer to kebajikan. But some are doing it with their own friends. It's suka sama suka. And they have no clue. Mereka totally clueless that mereka boleh dapat HIV, syphilis, gonorrhea. Dia tak sedar dia boleh pregnant kalau dia ada hubungan seks dengan pasangan-pasangan. You think in this day and age semua dah tahu kan? Tapi no, they don't know. So one is they tak tahu. Two is dia tak tahu nak cakap no kalau partner dia force ataupun the partner is a family member yang lebih tua daripada mereka. So we have to empower them. Kita kena berhentikan this thing. If we don't start it from school, because of course we should talk about it dekat rumah kan, tapi a lot of parents memang rasa macam segan nak cakap, tak tahu nak macam mana nak approach the topic with the remaja, and now it's very hard to handle remaja kan. So it's better that you do it in school with the peers, with the students, but you need to teach them. You cannot put the head in the ground and kata, oh, kalau you cakap pasal seks, mereka akan lakukan seks. Hello, they are already melakukan sex all over the place. Okay, so we need to teach them to do it the right way if they have to do it. Otherwise, tak habislah cerita ni kan.
Betul tu. Ada para panelis ada tak apa lagi nak tambah selain daripada apa yang telah dikongsi daripada Dr. Vicky?
Okay. Actually saya sikit je lah, tak banyak. Sebab ini pengalaman pengalaman saya sendiri yang saya dengar dari ibu. Dia ibu tapi dekat hospital dia sister. Dia ibu tapi dekat hospital dia sister. Dia ada 2 cap yang dia pakai. Okey, apabila dia dekat rumah, anak dia ada yang sulung umur 22 tahun. Dia pun bagi tahu. Dekat situ kalau dia video call kan, apabila video call anak dia sekolah sukan punya, kalau dia video call, lepas tu dia terus tanya, ibu dia terus cakap, Alung, siapa kat atas tolong? Kawan Alung. Kenapa dia buat Alung macam tu? Alung kalau nak buat apa pun pakai kondom tu. Ibu dah selalu bagi tahu kat Alung, pakai kondom. Itu manusia yang pertama saya pernah dengar dia encourage anak dia macam tu. Manusia pertama yang pernah saya dengar kat cuping telinga saya, dia encourage anak lelaki dia dengan anak perempuan dia. Dia selama kalau cerita dengan kawan-kawan satu table, dia akan cerita anak dia tentang safe sex ataupun dia dedahkan anak dia dengan benda-benda yang orang cakap sepatutnya ilmu yang perlu ada untuk keselamatan diri supaya diri sendiri tidak bergantung dengan rawatan. Itu sebenarnya. Bukan kita apabila kita mengajar macam mana pakai kondom, bukan sebenarnya kita tak menggalakkan, tapi ini pengalaman pak cik dia minta tolong. Tolong pakcik, mula-mula budak ni tolong. Lepas tu budak tu kedua suka. Lepas suka apa jadi? Tapi tak ada safe kat situ. Dia tak ada, macam orang cakap pendedahan seks selamat. Okey, kalau pakcik nak minta tolong, boleh tak pakai kondom? Kalau ada yang macam tu, beruntunglah. Pakcik minta tolong. Kalau ada yang macam tu, beruntung. Pakcik dia siap ajar cara pakai kondom macam mana. Yang kalau macam tu beruntung. Kalau ada pakcik yang jenis dajal, ini kes tau. Saya sendiri dengar. Ini reality. Mula-mula kakak saya tolong pakcik. Lepas tu saya suka. Lepas tu makin ramai saya tertarik. Kawan-kawan saya datang rumah bertukar-tukar. Mak dia tak heran. Mak dia tak ada question A. Mak dia memang tak ada question A. Itu orang cakap kita sebab tak ada terdedah. Kita macam itu lah cakap cisgender. Dia tak ada support group dia orang. Dia orang tak tahu macam mana nak handle benda ni. Macam komuniti MSM beruntung, komuniti female SW beruntung sebab dia orang banyak program, komuniti PL-HIV dia banyak program, banyak terdedah dengan benda-benda macam ni. Lepas tu yang kaki tangan hospital macam yang mostly lah yang kerja dengan ID klinik, dia orang lebih peka dengan benda macam ni. Dia orang lebih terbuka, tetapi luar daripada ID klinik, apa yang dikatakan tadi, memang banyak berlaku insiden yang banyak berlaku adalah luar ID klinik yang banyak jadi burden, yang banyak jadi komuniti, jadi stigma. Tak naklah datang sini disebabkan Kak Mun je saya datang sini, alhamdulillah. Itu je lah.
Thank you. So seperti apa yang telah dikongsi daripada Dr. Vicky dan Kak Mun, pendidikan seksuen memang penting pada setiap peringkat, bukan sahaja di dalam kawasan persekolahan dan juga di dalam rumah. Ibu bapa dan juga cikgu-cikgu dan juga masyarakat umum perlu memainkan peranan kami dalam memberi informasi seksual dan reproduktif yang betul kepada belia dan juga remaja. So seperti tadi juga apa yang Dr. Vicky pernah kata, remaja sekarang terjebak kepada unsur-unsur macam pornografi di dalam online, di internet apa-apa. Adakah panelis rasa social media boleh menjadikan antara satu intervensi yang berkesan untuk mengurangkan cases jangkitan HIV di Malaysia dan juga menggalakkan komuniti-komuniti yang berisiko untuk dapatkan ujian saringan atau dapatkan rawatan?
Okey, untuk social media dia sebenarnya macam ni lah. Sebab yes, platform social media ni dia besar. So bila wartawan hadir ke sesuatu tempat bercerita pasal HIV apa semua, wartawan ni adalah dia main satu peranan yang sangat penting untuk memberi macam mana cakap, masyarakat ataupun dunia tahu bahawasanya HIV ni macam mana. Sama ada HIV ni tahap yang bahaya yang macam mana, apa itu HIV, apa itu AIDS. So dan sosial media juga boleh menyebabkan seseorang tu dia takut dengan self-stigma lah kan. Bila ada contoh seperti macam HIV membawa maut. Ya memang betul membawa maut. Tapi kalau you dah ikut rawatan, you dah makan ubat, tak skip ubat apa semua, you maintain sihat. So peranan media sosial di sini sangat-sangat penting. Dan tolong kalau boleh setiap perkataan ataupun tajuk-tajuk yang nak buka dekat surat khabar ke apa, whatever pun, biarlah guna perkataan yang sesuai. Janganlah sangat-sangat stigma dan diskriminasi, please kan. Sebab di dunia ni HIV ni orang tak heran dah sebenarnya pun. Pada I lah, I tak tahu orang lain, tapi pada I kalau orang cakap dia HIV, biasalah sana macam mana kan. So kita bagi suruh dia buat rawatan, suruh dia makan ubat. Semalam I dapat satu call daripada rakan organisasi kita. Dia kata ada seorang klien lelaki dan dia PL HIV lah. Kata okey, so pasangan dia tahu dia ada HIV. Okey, baguslah kan. So you nak berkahwin, so you kena tahulah pasangan you. Akak ada tak apa solution macam mana kita nak ni ataupun nak bagi dia counselling ke? Tak payah nak counselling, tanya je. Kalau dia mulakan rawatan, dia dah makan ubat, dia dah viral load apa semua okey, kahwin je lah, apa masalahnya? Kan? So member I cakap, okey. Kalau dengan I sangat simple.
Okay, I tengok semasa Kak Ita kongsi tu, Cik Mun asyik, angguk kepala, mungkin Cik Mun nak tambah sedikit. Macam setuju sangat apa yang dia kata.
Actually sebenarnya benda ni memang selalu berlaku lah. Dekat mana-mana pun insiden dia akan berlaku. Kalau orang tu dapat macam contoh, ini contoh yang saya bagi tahu memang serial berlaku. Kalau dekat klinik hospital dia selalu berlaku sebab saya bertugas di ID klinik. Apabila kita bertugas di ID klinik, kita selalu dengar pakar berbincang. Bila pakar berbincang ni, contoh kalau ibu tu mengandung, lepas tu sebulan lagi nak bersalin. Apabila sebulan lagi nak bersalin, ada berapa minggu lagi di situ. And then apabila benda tu berlaku, doktor akan bagi dia rawatan untuk percepatkan virus tu supaya tidur. Dia ada rawatan dia sebenarnya. Banyak benda tu, tapi kita nak bagi tahu benda ni sebab benda ni adalah pakar sahaja yang boleh decide sebenarnya. Dia ada ubat yang boleh buat virus tidur dalam masa 12 hari. 2 minggu je dia boleh buat virus undetectable. Ini anak dia boleh sihat, ibu boleh bersalin macam biasa, tidak merisikokan anak. Itu salah satu. Lepas tu berbalik pada Kak Ita punya cerita tadi pasal nak berkahwin. Sebenarnya kita tak boleh halang. Kalau kita halang pun dia akan jadi deported. Kalau deported lagi banyak lagi menyebar. Better kita suruh dia kahwin. Lepas dia kahwin, datang balik, bawa pasangan, kita mulakan rawatan. Kita saring dia punya pasangan, tak ada apa-apa, ambil prep. Bila masa wanita tu subur, dia punya hormon subur, masa tu lelaki pun dah undetectable. Atas dasar nasihat doktor, buang kondom. Ada time dia buat kondom sebab nak merancang untuk dapat anak. Itu je. Tapi apabila buat benda lain, setiap hari nak buat, pakai kondom. Sebab kita tak tahu dalam badan kita ada virus beli. Apabila virus beli ni, kadang-kadang saya dulu makan ubat 12 jam. Orang lama otai katakan kan. Orang lama saya pernah jumpa apa yang doktor cakap tu, ubat yang besar. Ubat yang besar tu saya pernah jumpa. Ubat tu melekat dekat gigi. Saya pernah jumpa. Time tu memang time saya. Saya mau otai. Ini otai ni orang lama dengan rawatan HIV. Memang lama sangat dengan rawatan HIV dah.
Okay, thank you. Thank you banyak-banyak kepada semua panelis atas perkongsian mereka. Kita sudah sampai ke penamat live forum kami pada hari ini. Terima kasih banyak-banyak kepada panelis kami yang telah banyak berkongsi pengalaman mereka, pandangan mereka sepanjang tempoh berkhidmat dengan komuniti yang berisiko. Dan dari pihak penganjur, kita ingin menyalurkan penghargaan kepada para panelis dan juga semua peserta yang menyertai aktiviti live forum pada hari ini secara fizikal atau secara online. Dengan itu, kita haraplah melalui live forum pada hari ini dapat memupuk semangat bekerjasama dengan Kementerian Kesihatan atau klinik kesihatan atau hospital, community member, NGO, dan paling penting belia dan juga remaja di negara kita. So dengan itu, sekian, terima kasih. Sila bagi tepukan kepada panelis kami pada hari ini dan saya akan hand the floor kepada DMC. Terima kasih. Nak ambil gambar je boleh? Ambil gambar boleh. Sekarang tu? Sekarang.
Kita nak tutup gambar ni. Kita buat gambar ni kat mana? Ini duduk posing bebas.
Bebas.
Thank you all speakers for the knowledgeable forum. On behalf of Taylor's University, we would like to invite Dr. Wong In Hao on stage to hand over the token of appreciation to the moderator, Mr. Jeremy. And to our panelists, Dr. Vigneswari, Puan Siti Marlarita, and Miss Moon. Ladies and gentlemen, we have now come to the closing ceremony of our World AIDS Day 2021. Please fill in the feedback form to obtain the e-certificates. The link is being sent in the chat box. The seat. Just a moment. So the CPD points QR code will be projected on the slide in a moment. So we'll just have.
It's lagging.
Okay. Alright. Okay. So you can go ahead and scan the QR code for the CPD points. Alright. So I think we'll just give like around 1 minute. I would like to take this opportunity to thank all the organizations that supported our public talk and forum. Thank you, Kementerian Kesihatan Malaysia, Federation of Reproductive Health Associations Malaysia, Malaysian Health Council, Twin Catalyst, KLASS University Medical Society, Persatuan Insaf Murni Malaysia, Kuala Lumpur AIDS Support Services Society, and Pejabat Kesihatan Daerah Petaling. We really appreciate it. Special thanks to Dr. Lim Suin and Dr. Priya for their leadership and support. And I would like to thank our fellow participants for this event. We sincerely hope you have enjoyed this webinar. We couldn't have done this successfully without. With that being said, we would like to have a photo session with all of you. So there'll be 2 photo sessions. So one would be for the Zooms session. Can you kindly turn on your camera? You will all say World AIDS Day, and there'll be another photo session on stage as well. So may I also invite all the speakers on stage to take a group photo with the KLASS University and FRAM representatives.
Okay, in 3, 2, 1, I'm going to take a snapshot. 3, 2, 1.
Can everyone please turn on their cameras so we can take a picture? Alright, the count of 3, yeah? Alright, 1,